Hello, thank you so much for joining us and welcome to MD Newsline. Please introduce yourself to our audience.
Oh, thank you so much. I feel honored being here today. I'm Kamrun Naher, one of the endocrinologists in Brooklyn. I came here in ACE. My experience at ACE is truly wonderful. I feel like I get connected more here with amazing people, and I'm excited to apply what I've learned in my practice.
Great. So, you did two posters here at ACE.
Yes.
So, tell me a little bit about that.
Okay, so I really want to share the most interesting case that I presented at the poster presentation. The case was like we described a patient who presented with psychiatric symptoms and hypoglycemia, and later on he was diagnosed with neuroendocrine tumor, which is not the usual presentation.
Wow. So, yeah, tell me, how did we get to the actual accurate diagnosis? What was the process and what can we learn from this?
So he was a guy who was like sleeping well, like more than 6 hours every night. But all of a sudden, he noticed that he couldn't sleep like before. He was sleeping like 1 to 2 hours per night, who was unusual. And like deprived, sleep deprived, he was depressed. And he had the symptoms of low sugars. He was shaking, sweating, so he was eating a lot. So he couldn't tolerate all these psychiatric symptoms of depression, not able to sleep. Imagine you are not sleeping, and last few days he slept only 1 to 2 hours per night. So he got desperate and he did a suicidal attempt. He stabbed himself on the chest, and that's what was reason for admission in the hospital for chest wound. So when he came in the emergency room, and they did definitely all the workup and the CAT scan choose to see the chest because it was a deep wound with the knife. Then they found a lesion because chest scan was done from the chest and the belly. They found a lesion in the pancreas. And in the emergency room, he was frequent hypoglycemia, meaning low sugars. Lowest was 28 milligram per deciliter. So he was treated with hypoglycemia. When they called endocrine for hypoglycemia, we definitely recommended the workup for biochemical workup for hypoglycemia. And his symptoms was improving with the glucose. So he completely met the criteria Whipple's triad to diagnose him as hypoglycemia. So we had the biochemical workup, and the meanwhile they also consulted us because he was like what to do with the CAT scan finding that was showing some nodules in the pancreas. So when we confirmed biochemically that he is hypoglycemic because of high insulin, we started thinking about the neuroendocrine tumor in the pancreas. So we obtained an MRI which showed there is a mass sitting in the head of the pancreas. So eventually, we did all other biochemical workup to rule out Mann syndrome, which is part of this neuroendocrine workup. Because when you have a tumor in the pancreas, you want to rule out other part of the syndrome. So we did all biochemical workup, but eventually he got surgery. He got the mass removed, and the pathology confirmed us it was really a neuroendocrine tumor. And we did all the genetic workup, but fortunately he was not positive for any of those. And part of the workup for the syndrome, we did MRI of his brain. We found there is a lesion. We thought that it could be related with the man one, but the lesion was less than a centimeter. But he didn't have any other symptoms of anything. But again, he had eventually got nephrectomy because he had a lesion in the kidney as well. But he continued follow up, like after hospital discharge, he continued follow up in the clinic when he was coming, and like he was so happy that after the surgery he didn't have any low sugar symptoms. He was able to sleep. You can see the difference because we saw him as inpatient, completely different person when we saw him as outpatient. It was amazing seeing his experience, his smiling face finally.
Wow, that's really amazing. What do you hope to apply from this work? I have so many questions, but what is your kind of vision for how providers can kind of learn from this case study? Because I mean, him getting to the point of attempting is obviously pretty serious, and so I'm wondering what was missed or how we could kind of get to it sooner. But what is your initial vision of how this can be applied in a clinical setting?
So imagine this kind of patient who was suicidal and like hitting himself with this attempt. So this kind of patient is taken care by the behavioral health, because they will think, oh, patient is psychotic. You know how we treat this kind of patient, then he will be in the behavioral, the doctors will evaluate for psychiatric. But we have to look underneath, like deep, could be this is the symptoms that can be from other disease. Insomnia is a general, like is a word, but it can be the symptoms of many disease. So all the differentials should be in our mind. We shouldn't judge a patient that he was suicidal because of like he is depressed, but he was depressed because he couldn't sleep, and that reason was behind, like this tumor was making all the symptoms. That's why he was not able to sleep, and also the low sugar symptoms.
Are these kind of mental health manifestations common with hypoglycemia?
Not really, but somewhat, I would say, because when you get low sugars, at some point you get upset and depressed, frustrated. You don't know what to do. Like how many times you should keep eating and you are gaining weight. You are frustrated. What's going on? Something is wrong with me. So I would think, like I would say, mental health professionals should also keep look into it. Like this could be symptoms of one of some serious medical condition.
Yeah, that's really because it's fresh on my mind, making me think of things like, e- encephalitis and things like that, which is often misdiagnosed as mental, because it has psychiatric manifestations. And in my mind, I'm thinking, oh, if you get admitted, especially for something like an attempt, you're likely to be diagnosed with something and prescribed a medication that then kind of sends you down a rabbit hole. Um, do you think that this is a fairly unique case, or like how does this kind of play into the landscape overall of people with this type of hypoglycemia or even this tumor?
Yeah. So I feel like that's why we wrote the case, because usually the symptoms are low sugar symptoms, hypoglycemia. But I know, like I'm not experienced that much. I started my career last year, but within my short experience and the literature review, it was very unique symptoms with suicidal attempt, not even like depression. It's like a suicidal attempt. This is a lot advanced. I would say the mental health professionals should really take like deep into it, and we always keep our eyes and ears open for this kind of symptoms.
Yeah, and that really highlights for me the importance of this kind of like whole, I don't want to say holistic, but this kind of multidimensional view of patient health, because so many symptoms overlap. Do you have any thoughts on how you see maybe even record keeping technology and things like that impacting how we see patients as a whole when they come in with symptoms that might overlap with other things? Have you kind of thought about that a little bit?
Yes, definitely, like multidisciplinary approach. So if this patient was not like approached in a certain way, we could have missed the diagnosis. And I'm happy that for hypoglycemia, because if there was no hypoglycemia, they will not call the endocrinology like to diagnose this case. I definitely agree. We should keep a multidisciplinary approach for any cases, especially this kind of suspected cases. And thank God that they saw the CAT scan. There was a tumor, which made them to call the endocrinologist on top like of hypoglycemic symptoms. So I'm happy that we got into the case on the perfect time.
And that tumor being found on the CAT scan, that was just incidental, right?
Incidental.
Yeah, wow. In looking back, were there any other symptoms, and or what would the progression of this have looked like if it hadn't been caught?
Okay, so he was gaining weight because he was hypoglycemic and he was eating well, like very, like to prevent the hypoglycemia, definitely. And he was gaining weight at the same time of depression. But this type of neuroendocrine tumors, when they involve like other hormones, they can have multiple other symptoms. But in his case, the psychiatric symptom was like very unusual presentation in this case.
It's very interesting. Wow, that's great. Tell me a little bit about your other poster.
Okay, so the other poster was about pheochromocytoma that in my fellowship I couldn't find a lot of cases, but I'm fortunate in my first year of practice I found multiple cases like when I was consulted as an inpatient, and I don't know, maybe I was like looking into the hypertension, that those are the symptoms of pheochromocytoma, and in a month of consult I got 3 cases. Those are very interesting, and I bought them in the like outpatient clinic for follow-up, and eventually we diagnosed as pheochromocytoma, and it was really interesting in a month, which I didn't see in my fellowship in like 2 years. Like 3 cases is amazing. So that's the reason like we were like to uh, let other people know like what was the spectrum of symptoms pheochromocytoma can present with.
Yeah, tell me a little bit about the chromocytoma for the members of the audience, including me,
Yeah.
who's not familiar with it,
Okay.
please.
So pheochromocytoma, this is a disease of the adrenal medulla, the adrenal gland. There is 2 glands above the kidney, and these tumors arise from in those glands. But the symptoms are very interesting. They will have episodic palpitation, chest pain, or sweating, excessive sweating, sleep disturbance. But these are episodic. Some people think, oh, this could be normal, but might not be normal, that you are thinking normal but not normal. So the first case that I had, he was telling me that he sweats when he lifts heavy weight. He thought that it's normal for him because he was lifting something heavy, which was like normal, anybody will sweat. But no, this was episodic while he was lifting weight, when we looked on the hind back, like when we look on the back. But the reason for this patient presenting to the doctor in an emergency room was his chest pain and the palpitation. He ignored his symptoms of excessive sweating, like when he was lifting weight. So that was like interesting, I would say.
That is interesting. What other data did you gather about this particular case? Because especially when I think about using technology to look at things like case studies and clinical trials and stuff like that, and thinking about the fact that there's so many elements that we don't know that kind of impact how diseases present. Um, when we look at these cases, are you thinking maybe more expansively about what other data that we maybe can collect, and what data did you end up collecting around the case?
So, like all these 3 pheochromocytoma case, I was thinking like the data's like how the patient present. Usually, we do not go to the doctors if unless we have some debilitating symptom that is affecting our quality of life. So I think these cases get delayed diagnosis, or already the damage has been done to their heart or kidneys, and that's some point they present. I feel like we should find out the symptoms earlier in the disease process, where we can take the necessary step and prevent the complication in terms of cardiovascular and the renal complication. Those are 2 vital organs for a human.
Mm. Are there any comorbidities that tend to pop up with this that maybe could be a signal?
Yes. So the pheochromocytoma, if we don't get diagnosed them on the right point, if it damage happens to the renal function and the cardiovascular dysfunction, so you are like already have the complication. Rather, when you remove the tumor, you have already the comorbidities, like you already have done enough. You cannot reverse those complications. So it's very important to catch them early to prevent the complication, which can increase the survival of the patient.
Hmm. Are there any lifestyle, genetic, or any exposure factors that kind of increase the likelihood of this diagnosis?
It was like definitely it has the genetic thing. So whoever is diagnosed with pheochromocytoma, we ask them to the offspring, the family members should get the genetic counseling and the testing. So that makes a huge difference, I would say, because if he wouldn't present, we would know that he has the disease. He will have the complication down the years, and his offspring will also not get like diagnosed or screened for the genetic syndrome.
So it's definitely like a for sure manifestation of that disease through through the parents or through the bloodline or what?
This is one of them, because there are multiple reasons. This is one of the reasons, the genetic, but could be other reasons, multifactorial. It's not only in the family or like genetic, I would say, but there are others. The studies, there are not enough data to tell us exactly what is the reasons.
So are there changes or maybe recommendations to conversations that providers at different levels should be having? Because obviously when you get to the point, I mean, outside of the attempt, but even if, there was an attempt, you would still have this tumor and whatever would follow with that. What should providers be doing before we get to this dire point to maybe help increase the likelihood of catching this at a more opportune spot?
Yeah, so that was our main thinking point. We want the providers to be aware of their patient symptoms. I want all the providers should be asking to their patient, what is not usual to you? What is not normal to you? Such simple questions. We could have find like maybe this patient, if he would go to the provider and the provider would ask, what is not usual with you? He would tell that I sweat when I lift heavy weight. That was normal to him. But if you ask question, because you don't know the symptoms of the disease and might feel some palpitation, or you see your face red, flushed, maybe the family members noticed you, but you couldn't realize. So I would say these kind of symptoms, they get unnoticed and they get delay the diagnosis of like such a disease that has a huge bad like complications and comorbidities.
Yeah, that question of what is normal to you, I think, is kind of like a really important linchpin to misdiagnosis, because I feel like even people who deal with chronic stress, for instance, right, what's normal to them is not actually quote unquote normal, right? Like I think people sometimes they live with certain symptoms and they're just like, yeah, this is how it is. Doesn't everybody do that? Until one day your doctor's like, nope, everybody doesn't experience that. So yeah, I'm wondering just from a patient education perspective, are there any other places that you think that we kind of miss communicating with patients? Any other opportunities to help kind of diagnose things sooner as far as patient education and raising awareness in patient populations?
So definitely, I agree with you. Patient education awareness, that is most important. I feel like pheochromocytoma, the symptoms and the presentation is not that common, so we don't have the awareness. That would be great if we can create the awareness. I think social media would be the great, because in that case it's easier to spread the symptoms awareness strong, so that everybody knows. If you don't know, like you will not see anything if your mind doesn't know. So if we can create that awareness, I think in future we'll see the diagnosis of pheochromocytoma is going higher and higher, although we have it maybe undiagnosed.
What is the general impact of this diagnosis on populations? Are there any populations that kind of get this diagnosis more often than others? And overall, I don't know what the main population was like in America, for instance. Like, what is the overall impact when you say rare? Like, what percentage is that generally?
Yeah. So unless they have complication, they don't present to the doctor. But there were cases. Out of 3 cases, one of the cases was a cancer patient. Cancer patient was getting treatment for chemotherapy, oncology. The patient has endometrial cancer, and when they treat the cancer, they definitely do the CAT scan of the whole body. This is called pan-CT to find out the metastasis or the disease status. At that point, patient was found to have an incidental nodule in the adrenal gland, and that made them work up. Like, so I'm just want to tell that patient didn't have like typical symptoms of pheochromocytoma. Patient had generalized weight loss that can be from the secondary to her primary cancer, endometrial cancer, or the chemotherapy. But unless this nodule was found on the screening for the cancer, we will not know this case. So I think this is interesting.
Yeah, I feel like, nodules and incidental findings, it almost feels like there's some diseases that are most often found incidentally when we do certain things. I'm kind of wondering just with recommendations and things like that, when people do things like CAT scans and MRIs, do you see a way to kind of maybe potentially build into the process the ability to find things that are more likely to be incidental? Like, have you thought about that at all? Because it doesn't seem like there's a real solid fix for it, because some of these things are only found incidentally and their symptoms often overlap. Like, what are your thoughts or musings on how we can kind of pinpoint things that are usually only found incidentally?
Yeah. So yeah, that again, the awareness, multidisciplinary approach, the provider between the patient and provider, the symptoms. But again, some people like have very overlapping syndrome that I agree. And in that case, I would say like everything incidental that we find because of the increasing advancement in technology, we have now multiple like advanced technology that we are finding this incidental finding and eventually getting them diagnosed. I would say should start from the primary care providers clinic, their yearly screening, their regular follow up, annual exam. I would say this is very important. There are patients in the community, they didn't see their primary care in last 3 to 5 years last. So I would say regular annual follow up with your primary care can make a difference.
Wow, yeah, that primary care visit is seems to be
Yeah.
the first point of contact for so many things and opportunities. Is there anything else that you're excited about with either one of these studies that we haven't covered so far?
Yeah, I'm excited about getting more cases and following up and finding out the genetic correlation, how much they are related, or are they more sporadic or more genetic? Yeah, looking
Interesting.
forward for more.
Yeah, and I'm wondering just from just the landscape of what we know already, is this kind of something that's passed on from the maternal or paternal side, or is it, do both parents kind of have to have the gene? Like, what do we know so far about maybe some of the genetic aspects?
Yeah, it could be like it doesn't need to be both of the parents. It could be autosomal dominant, meaning if one parent have it, the other like offspring can have it. So that's why the genetic counseling and genetic testing is very important at the diagnosis.
Hmm. And then, just based on what we know so far, is this something that people can be tested for even if they don't present with the illness, or?
For the genetic testing,
Hmm.
you mean? Genetic testing is very expensive. It's not easy to get, but I would not say that everybody should be screened for genetic testing. That would be like huge burden in the economy of United States. So I would not suggest genetic testing for each and every single person. But definitely, if the primary care provider visit, they had like new onset of hypertension, new onset of palpitation, new onset of some chest pain, or excessive sweating, something is wrong. These are the more areas I want everybody to be aware of, and maybe those kind of people like young patient, all of a sudden hypertensive and like fluctuating hypertension, fluctuating palpitation, chest pain. The primary care provider, they can give a diary, like they can maintain their notes, which days he was like getting symptoms and did he check his blood pressure on that day. That would be amazing. That would be easier to screen who needs further testing and who doesn't.
Great. Thinking about the conference in general, are there any other things that kind of stood out to you that you thought were exciting, whether it be the poster session or any of the keynote
Oh,
sessions at all?
yes, of course. The conference was amazing. I told you, it truly had a great impact on me. I feel like I'm more connected and I'm learning a lot. And I had a lot of questions like clinical practice. We are confused sometimes with some complicated case and we don't know which decision to take in terms of like patient benefit, and you have the other risk to cut down to prioritize which one. So it helped me a lot, and I would say we shouldn't like miss this kind of like conference. I'm very happy, very inspiring endocrine community. I would say that we are lucky to have this kind of conference so that we can share our thoughts, we can learn from each other, and we can build connection like bigger community.
Yeah. Are there any kind of particular insights that stuck with you the most from the conference at all, or anything that you think is gonna the most heavily impact your practice moving forward?
Yes. So now that we came to the conference, we are practicing like according to the guideline based on the patient and our experience. But definitely from like whatever like last 3 days, I would say very valuable and inspiring these days. There are not only one, two, three. I can't explain in words. There are a lot of things that I'm planning to like apply in my practice practice when I
Mhm.
go out.
And then what are the next steps for you in your research? You talked about maybe continuing to follow up. Are you gathering or still searching for kind of these case studies,
Yes.
and how are you following up with some of the cases that you've already identified?
So the three cases that I have, one, two others, we are still following up, and meanwhile we're gonna find like if there are other cases like this, and the genetic testing that I wanna see, like how are they and the syndrome men one or like other men syndrome, are they, how common they are in the community, like I'm looking forward to it. Maybe next conference I would come up with more case series so that we can at least have an idea of what are the spectrums they're presenting and how they're genetically like more correlated or not.
And is there a specific geographic location where you're searching for cases? How do let's say if there's a case identified at Northwestern, for instance, in Chicago, how are you kind of gathering those cases?
So for now, for this instance, I'm gathering the cases from the from my practice that we in Brooklyn, New York. But I think eventually, when my number of cases goes higher, I might invite other facility all over the United States, maybe because we are meeting here in ACE conference, and in future maybe all over the world. We can like create connections, social media, and we can gather cases, and maybe we get more cases from other part of the world in the United States, then we can have more bigger studies on
Mm.
that.
Yeah, I wonder about that a lot too, just because, especially with rare diagnosis. Even when we think about things like personalized medicine, and we find that people with various life experience, whether you're talking about the epigenetic factors that come into play, there's so much that we don't know that I feel like we need to make sure we gather as much data as possible.
Yeah.
But if someone isn't like explicitly doing like a study and recruiting people, I feel like this data is just siloed in different places. I'm wondering, is there in your field, is there any kind of hub or place for people to kind of gather rare cases of particular diagnoses, or does that exist, or is it all kind of from a case by case basis, where each kind of doctor is doing their own work to kind of understand the cases around them? Does that make sense?
Yeah. So for now, we don't have something like that, the hub that you are talking about. But I'm thinking like if we get more, like as I said, just started my practice last year. If
Mhm.
we get more, we might be able to organize a team, like looking for interesting cases and get them connected and keep follow up, like not like other regular people who are healthy controlling their disease, the rare cases. Maybe we should have might be able to create actually a special group for that, in terms of resident fellows, even the office like team ancillary staff and everyone.
Perfect. Thank you so much for taking the time to share your work with me. Is there anything that we're missing?
Oh, thank you so much for inviting me. I'm like so happy to be here, and I'm happy to share my cases. And at least I think I it might have effect or awareness among general population.
Definitely. Thank you so much.
Thank you.
It's been a pleasure.